Hi, everyone. Welcome to our monthly or bi-monthly SCI topic reviews and in-service. Today, Dr. Mike DeCapua will be talking a little bit about spasticity management following spinal cord injury. And I think we often focus a lot on the pharmacologic side, but as we know, it's a spectrum. It's a spectrum from when they're in the ICU to the time they're at home. So with that, I'll hand it over to Mike. Mike?
Thank you very much. I'm Michael DeCapua. I'm one of the new PGY2s here. I thought it'd be important to start off by speaking about spasticity management. It's something that's unique to a couple of different subsets of patients here that we see in PM&R, and it's something that I personally did not have a ton of exposure to in my medicine training. So I thought it was a good way to kind of get an introduction into the options for treatment for patients. This is by no means a comprehensive and exhaustive list. It's sort of an overview. And if anyone has any specific questions or follow-up that they'd like to add in, please feel free at any point. There we go. So first, I just thought it'd be great to just kind of cover what spasticity is. So just briefly, I thought that this definition was a good one. It's it's a motor disorder characterized by the velocity-dependent increase in tonic stretch reflexes, which is muscle tone, with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex. And it's one component of an upper motor neuron syndrome. So I looked at this as, focusing on the hyperexcitability and the increased tone. And we can see this in a variety of different conditions: post-stroke, MS, cerebral palsy, brain trauma, and what we'll focus on today mostly is spinal cord injury, but acknowledging that this is something that happens in a variety of different patient populations. And management is relatively similar, but we do see some things that are well studied in certain populations versus others. Another thing that we look at is there are multiple ways to kind of objectively look at spasticity, one of which is the modified Ashworth scale. This is a 0 to 4 scale, 0 being no increased tone, 4 being essentially contracture affected, with the affected part being in rigid flexion or extension. And it does have grades of 1, 1 plus, 2, and 3, which is increasing in the effective spasticity in that affected limb. I think it's important to realize that there is this and many other grading systems that can be used, and it gives us an objective measure of the degree to which the arm is or leg, whatever limb is experiencing spasms or spasticity. One thing that I came across when looking at this was that spasticity is not always negative. There are definitely negative effects of it, and that can be the pain that's associated with it, the painful muscle spasms, the development of contractures. It leads to a decrease in mobility of that affected limb. It can affect the patient's sleep, and it can promote difficulty in performing ADLs and other functional tasks. But in some cases, actually having some increased tone in certain spots can assist the patient in performing these ADLs or creating a functional ability in a specific limb. Also, with the increased tone comes increased blood flow. So there's some literature that suggests that the increased blood flow can help reduce DVTs, the chances of orthostatic hypotension. It can maintain some muscle mass, and overall does have some possibly positive effects in improving the function for that patient. So I think just, when we think of spasticity, you don't always have to think of it being purely negative. There are some ways in which it can be positive, and we would be able to utilize it to our advantage, and rather than just always treating it. Also importantly to understand is that not always is this something random. There can be an acute stressor or an underlying cause that is leading to an acute change in the patient's spasticity, both in the inpatient setting and in the outpatient setting. So patients who may be bed-bound or wheelchair-bound, the development of new or worsening pressure sores, changes in bowel and bladder regimen. We see in our spinal cord injury patients very often that having a good bowel and bladder regimen is really important, and staying on a good regular basis. So any issues with constipation or urinary retention can lead to worsening spasticity, and it actually may be one of the earlier signs that a patient is having urinary retention or constipation. or possibly a sign of infection. So if there is an occult infection, increased spasticity or changes in spasticity pattern can be an indication that there is an infection going on. Also is affected by things like pain, fatigue, poor sleep, and stress can cause an acute increase in patient spasticity. So the first part, we'll talk about some of the pharmacologic efforts that we can use to manage spasticity, many of which we see both in the inpatient and outpatient setting. And then we'll kind of get into some of the non-pharmacologic or adjuvant treatments that we have available to us. So the first medication we'll talk about is baclofen. Baclofen is a GABA B agonist. It works by postsynaptically binding to the neuron and inhibiting the action or interrupting the action potential by allowing potassium flow. Some places kind of indicate that it's effective by reducing flexor spasms. Importantly, it is a medication that has pretty good long-term use data, and there's no development of tolerance to it. So generally, patients can do pretty well on a standard dose for quite some time. As we transition from med students to residents to attending level, I think at least early in training, it's important to kind of understand some of the pharmacologic aspects in terms of dosing, which ways we can increase and how to affect our prescribing. So baclofen typically comes in 5, 10, 20 milligram pills. A lot of times you'll start out at 5 milligrams Q8, and the suggested increase is by 5 milligrams per dose every three-ish days as needed until you achieve kind of improvement in spasticity that's both provider and patient driven. It's a conversation to see how the control is going from their perspective. The maximum suggested dose is 80 milligrams per day, and it is a medication that you should use caution in CKD patients as there can be a buildup of it and with clearance. So being cognizant of that when prescribing it to patients with kidney issues. The main side effect that we worry about is sedation with baclofen, but I think kind of a good thing to highlight is that if you are on this medication for a long period of time, specifically at higher doses, that abrupt cessation can cause this withdrawal syndrome, which kind of looks like altered mental status, in a significant jump in spasticity, can cause fevers, hypertension, tachycardia, even seizures. So being cognizant, if a patient has been on this for a long period of time and is no longer tolerating it, that it's a medication that should be tapered off slowly. And then I did include some of the pricing for the pills. I do think that this is pretty variable. This is at least what we had GoodRx, which I could find through Apocrypha. Next is tizanidine. So tizanidine is a centrally acting alpha-2 adrenergic agonist, works by inhibiting excitatory amino acid release and promoting glycine. It's said to kind of work with spasticity by reducing tone and the frequency of muscle spasms. It does come in 2, 4, and 6 milligram pills, and the suggested increase is by 2 to 4 milligrams per day with a couple of days between increases with a maximum dose of 36 milligrams a day. Again, this is a medication that should be considered for tapering if you're on it for a long period of time. There can be some withdrawal effects, and so it should be kind of a mutual conversation, maybe even consulting some more literature about how long the patient's been on it. Another medicine that we have to consider in CKD patients, decreasing the maximum dose that they can get in a day. And side effects for this also include the sedation, but also it is a central acting alpha-2 adrenergic agonist, so it can cause some hypotension, and it does have a possible hepatotoxic effect. Dantrolene is it acts differently. This acts actually in the muscle. It inhibits calcium release from the sarcoplasmic reticulum, and it interferes with the contraction excitation coupling. It reduces overall muscle tone, reflexes, and clonus. It comes in 25, 50, and 100 milligram pills, max dose of 100 milligrams Q6. And this is a medication that you really want to slowly up titrate. Generally, it's suggested that you don't up titrate quicker than every week. And there are some pretty standard increased like up titration methods that are available online for kind of getting up to higher doses. Very notably, there is hepatotoxic effect, and patients on dantrolene should be closely monitored with their liver function tests every couple of months. Diazepam is a benzodiazepine, so a GABA A agonist, and we know that this is a medication that's not as commonly used. It does have some good effects for spasticity, but there are a good amount of side effects with chronic benzodiazepine use, including confusion, sedation. This is a medicine that we use with great caution in our elderly patients, and especially when we have patients with other sedatives. So patients who are spinal cord injury patients, possibly from a polytrauma, who are concomitantly getting opioids or other pain medicines that can interact with benzos in a way that could cause some respiratory depression. So just being careful of that. Also, we know it's pretty well documented that there's an addiction and withdrawal potential to chronic benzodiazepine use. So being very cognizant of when we're prescribing this, but it does have some good effects on spasticity if needed. A couple other medicines we won't go into as depth in greater detail with. Clonidine, it's an alpha-2 adrenergic agonist. We use it a lot for agitation or blood pressure control, but also does have some effects similar to dizanidine with improving spasticity. Cyproheptadine is a histamine and serotonergic agonist, which will occasionally be used for spasticity management. And then cannabinoids. I will not go into this. It's probably an entire lecture in itself. But with more data, more studies, there are a couple of older studies that kind of looked at cannabinoids and its effect on spasticity. And there is some positive data that suggests that it can be used. But I think that more studies are definitely needed for that to be kind of more of a mainstream option. I would be remiss if I didn't speak on a couple of the other interventions here, but just quickly, an intrathecal baclofen pump is what is pictured here on the right of the screen. This is a pump that's implanted into the subcutaneous tissue of the abdomen with the drug delivery system going right into the CSF. So baclofen orally does cross the blood-brain barrier, but it has significant better bioavailability if it's delivered directly into the CSF. The dose adjustments are made through a computerized system. There are generally limited side effects of the medication itself when administered intrathecally. However, the post-op complications and the fact that there's hardware in the body is really what the main complications and side effects are limited to. And then botulinum toxin injection. So this works by inhibiting acetylcholine release of the neuromuscular junction. We generally see these effects about 1 to 3 days after injection, with a peak effect in 2 to 6 weeks. Patients can receive injections every 2 to 6-ish months. Limited side effects, mostly site reactions and weakness at the site of injection. But noting that this is something that patients may have specifically in the outpatient setting and is a more detailed lecture in itself, but it is a very popular and available option for patients. So noting that this is something we should just kind of briefly touch on. So next I'll talk about the non-pharmacologic management of spasticity. So we'll go into a couple different options for patients. These are generally used as adjuvant therapies in addition to medication management, and we'll go through some of the data that supports or doesn't support the use of each one. First we have is stretching. So stretching is one of the more common methods that we see with patients with spasticity. It's kind of on the older end of the spectrum now, 2008, there's a large systematic review that looked at stretching and its effect in spasticity for spinal cord injury patients. And this study itself had high amounts of heterogeneity, but overall the takeaway was that there were very few strong systematic studies that looked at the effect of stretching directly on spasticity. There was a highly variable treatment approach in terms of both the methods of stretching used, the duration of treatment, whether it was one session or multiple sessions carried throughout several weeks, which muscle groups they were targeting, the affected place of the spasticity, what exact exercises they were using, and even the different patient populations, whether it was post-spinal cord injury, stroke, and other patients experiencing spasticity. Overall, their main takeaway was that there was not a strong evidence to support its use, and that there should be more studies on this large of a scale to direct management for stretching. Again, this is generally used as part of an interdisciplinary approach, and some patients do have great benefit from passive range of motion stretching, and it can be used, and it's often used in both the inpatient and outpatient patient setting as part of the therapy regimen to improve a patient's kind of overall range of motion and thereby trying to improve the spasticity in an affected limb. I think that this is a really good opportunity for more studies in the future. It's a relatively low cost and possibly high benefit area for patients to experience more effects of what we're doing in conjunction with the medications that we're giving. Next is splinting. So again, looked at a couple of different studies, mostly looking at the effect of splinting multiple different limbs and areas and its effect on spasticity management. Most of these studies do mention that this is a treatment for prevention of contractures. Most of the studies that I could find in splinting were surrounded on actually post-stroke patients. There's very few direct studies that are looking at splinting in patients with spinal cord injuries and its effect on spasticity. Those that were kind of touching on it looked and said that there is some mixed data, that there may be some positive effects, but for the most part, it is kind of a mixed bag in terms of its overall effect on improving spasticity for these patients. Generally, this is considered part of the standard treatment approach, especially with patients with high-up cervical injuries. Upper extremity splints are often used for the prevention of upper extremity contractures and increased tone. It's an overall very low-risk intervention, one that patients can begin in the inpatient setting and often carry through to the outpatient setting and at home. And it does have some studies that do show its effect in a positive way. But I do think this is another area that a more standardized approach, possibly looking at which joints are specifically more benefited than others, specifically in spinal cord injury patients, it would be really beneficial for the patient populations that are affected by the spasticity and kind of could use something like this at home and in the inpatient setting. Next is these kind of quote unquote invasive physiotherapy measures. So those being acupuncture, electroacupuncture, and dry needling. So acupuncture is essentially the application of fine tip needles on different skin points. Electroacupuncture is passing pulses of small electric current through these needles. And these needles are inserted at what are called meridian points versus dry needling, which is using a similar type of needle, but is directed at trigger points. These studies, so a lot of which have taken place in Asia, do have some limited evidence. Most studies have looked at acupuncture and electroacupuncture, both of which have shown some promising data to support its effect on spasticity, even in kind of more of the short term. It, again, is another area where we don't have a standardized treatment approach in terms of both the duration and the exact muscle groups that benefit most. Another area in which we see most of the studies are directed at post-stroke patient spasticity and not a lot of data supporting post-spinal cord spasticity if there's any difference in those two patient populations. So I think it's a good way to kind of have a new study that would look at the effect of possibly acupuncture or even dry needling or electroacupuncture in different skin areas and muscle groups, and what that effect might be in the spinal cord injury patients versus brain trauma or post-stroke patients. Next we have is functional electric stimulation cycling training. So this is I wasn't very familiar with this. So this is essentially the placement of surface electrodes on multiple lower extremity muscles, including the quads, the hamstrings, and the glutes, which induces pedaling movement on a pedal. One large recent 2021 meta-analysis of the effect of this FES cycling training and spasticity, specifically in spinal cord injury patients, showed that there was a decreased spasticity and motor assessment score, and an increased walking ability, 6-minute walk test, lower extremity strength, and time to up and go test. So this was pretty promising. It did show that the overall meta-analyses showed that the average requirement was 20 sessions of FES cycle training for an effective decrease in spasticity and motor assessment scores. So I think it's a worthwhile area for more studies, future research. I don't recall the exact number of studies that were included in this. I think it was around 12. So still not a lot of standardized studies on exactly this method in spinal cord injury patients, but it does show some promise. And then finally, we have repetitive transcranial magnetic stimulation. So some people may be familiar with this. It's often used in depression, and it's a non-invasive, relatively non-invasive intervention for patients. And it generally is looking at directing a magnetic field towards cortical tissue with the goal of changing the excitability of the neurons. So for spasticity, it looks at targeting the motor cortex. So this study, that was a 2010 study, specifically looking at spinal cord injury patients, it targeted the transcranial magnetic stimulation at the leg motor cortex. And it did show that there was a clinical decreased response in spasticity for these patients. However, when they tried to follow up and measure it on EMGs and neurophysiologic data, it was not supported. It was not exactly reflected, but there was a symptomatic and clinical improvement in spasticity for these patients. So I think further studies, again, on this topic would be really helpful, as it's a relatively well-tolerated and non-invasive means that can improve spasticity in patients. Overall, some takeaways. I think as a PGY2, I think these are kind of the big things that I tried to take away from this. Identifying what spasticity is and discussing with the patient the effect of the spasticity on the quality of life, and then going from there to see if it needs to be treated locally or with systemic drugs. Always looking for and trying to correct the underlying problem if there's an acute worsening, rather than reaching for something like baclofen or tizanidine. Inpatient here, we use a lot of baclofen or tizanidine for spasticity management if it's warranted. We also are using other non-pharmacologic means. We have stretching, we have splinting available. So the other non-pharmacologic data, it's non-invasive. It's often included as part of the standardized treatment approach for these patients. It is a relatively low cost and well-tolerated therapy for them. And although it may lack some really strong supporting data, it's often can provide some benefit to the patients, especially in the short term. And I think it's a really great opportunity for further research for people, especially in the spinal cord injury patient population. I have included my references, and I'm happy to pass along any of the papers that I read as part of this background. Anyone have any questions?
Good presentation, Mike. This is Clay. A lot of our patients complain about sedation, especially acutely. Do you have any preferred agents after what you read for a patient that is complaining about that with spasticity?
Yeah, I think, what was that last part? I'm sorry.
I think that was feedback.
Okay. Yeah, so, I think baclofen and tizanidine generally seem to be the, two most common agents that we use. I think it's something that, especially both of which you can see sedation. It seems to somewhat be dose dependent. So if a patient can tolerate low levels of each drug, it may not be a bad idea to start with one of those and see how well it's tolerated at the lowest dose. If you're kind of more worried about it, I definitely would be avoiding benzos. It's probably going to be the least effective. So something like dantrolene is not a bad idea if the patient can tolerate it. It's a special consideration with his hepatotoxicity, but it is an option for patients who aren't able to tolerate something like the baclofen or tizanidine.
Yeah, traditionally we say that kind of Dantrum's is less centrally acting, so it should have less sedation than some of the other agents.
Good to know. Thank you.
Any other questions? Well, Mike, that was a. Oh, go ahead, David, please.
Sorry. Yeah, it's David. Good job, Mike. I had a question. This might be more so for Dr. Abramoff as well, but at what point in the algorithm do you go to like an intrathecal baclofen pump, like failure of medication, I'm assuming, but also how many of these kind of non-pharmacological treatments do you try first?
Yeah, I think it's a great question. I'll be fully honest. I tried to focus mostly on the medications and then transitioning to some of the non-pharmacologic treatments. From kind of what I gathered, it's sort of patient dependent. The effect of the intrathecal baclofen pump is, if a patient is kind of open to having it placed, and sometimes the systemic side effects of the oral baclofen sometimes aren't as tolerated. It may be kind of that might be one of the reasons why you're opting towards it. But Dr. Abramoff might have a better approach to exactly when in the algorithm you're reaching for that.
So I'd say there's a couple things. One, it tends to be somewhat like provider and site specific. Some places are very kind of quick to jump to baclofen pumps. Some are much slower. I think it has to do with kind of the providers and how much baclofen pump experience they have and how much they use it. So I've seen pretty wide variety, just practice by practice. In some ways, if it's severe and they've tried a couple of medications, I know like Shepherd will do trials when the patients are inpatient, which is pretty unusual. Some, will always try Botox first. I tend to try Botox first, but if somebody has severe kind of widespread spasticity after spinal cord injury, like throughout their lower extremities, specifically in, some of the deep hip flexors or, larger muscles that require a lot of Botox, you may just jump sooner to baclofen pumps. And then, there's a certain amount of commitment, that the patient needs to kind of accept with a baclofen pump, because it is a big commitment and there are some really serious risks, including pump emptying, running out, and pump failures. So that can lead to, life-threatening withdrawal. So it's something that it's kind of a mutual discussion with you and the patient about what they try. I tend to, in my outpatient visits, I think probably some of you have seen, kind of go through the different options with the patients and let them decide how aggressive they want to be.
Gotcha. Thanks.
And even there's even some more surgical steps if that fails, but those are really unusual usually, like rhizotomies and things. So Mike, again, very good presentation. A couple questions. When you say you kind of talked a little bit about like some of the benefits of spasticity. So when like what would indicate treatment to you? Like when to treat?
So I think it would also be a conversation with the patient to see what symptoms they're having and what effect it is having on their overall function. So increased tones, possibly in the upper extremity, in the hand, it can possibly help out the patient with doing some certain tasks. So if it's not bothering them and it's serving a purpose, I would imagine that that's kind of one of the reasons why you wouldn't want to treat it. If there's not really a negative effect on the patient's overall function.
Yeah, no, I agree with that. I think, traditionally what I say is, is it causing pain? Is it causing interference with your function or, self-care? Can your caregivers are they having trouble positioning you, turning you, getting you up in the wheelchair, doing your perennial hygiene? Those are the types of things that you want to ask about. Occasionally you have somebody who's like, it doesn't really bother them, but it's really severe, and you're like, I don't want this to kind of progress to contractures or anything, so you become a little bit more aggressive about it. But that's pretty unusual. And a lot of times patients just need education, like, hey, it's not a bad thing, it's the muscles firing. Just when it happens, lean forward, try to take the muscles off of some stretch to help calm down the clonus or the spasticity, and that can always be helpful. Another question, and these questions are more for the group because I'm not necessarily expecting Mike to know the answers to these. Has anybody read anything, or does anybody have different feelings about baclofen and using it in the acute period? Would anyone not use it in the acute period? Or heard of something along these lines?
I haven't.
Mike, did you see anything about that?
I did not look too deep into the differentiation of use of baclofen acutely versus in chronic.
And even so, there's some who think that in the recovery period of spinal cord injury, it's not safe to use baclofen, that it can impede neuro recovery. And this is based on kind of anecdotal and small animal models and rat models. It doesn't really bear out. It's been used for 40 plus years, maybe longer. So the evidence doesn't really support that necessarily, but there are acute rehabs that won't use it because of fear of impacting neuro recovery. I think it's somewhat unfounded at this point, but it is a consideration. Generally it's very safe. So that's one of the reasons why we like to use it. And then my last question.
We had a question in here. What's the time period for the acute window? Do you know what like months, weeks?
I don't know what other kind of institutions do or use. I imagine it's kind of the course of their acute rehab stay. Okay, and I would probably think somewhere in the 3 to 6 month range that they wouldn't use it. I've kind of heard this more through the grapevine than anywhere else about the institutions that don't use it. And I won't call them out here because we post these on YouTube. But I think it's I think it's an interesting discussion and something that's worth considering. But you have to be careful how you interpret evidence because all these meds have downsides too.
Makes sense.
At the same time, if it is impeding like 10% recovery, I think or 5% of recovery, most people would choose not to use it during that recovery phase. And then last question for the group. So we talked a little bit about increasing spasticity and what that might indicate. What if you noticed like a loss of spasticity? Like somebody was pretty spastic and they're a couple years out, and then all of a sudden, hey, over the last 6 months my spasticity went away, or last 3 months my spasticity went away. Any thinking there?
I think you want to re-image to look for like a new lesion or progression of the old. Changes in the exam.
Yeah, so yeah, definitely. This is actually gonna be a really early sign of things like Charcot-Stein and Syrinx progression. Because think about it, it goes from more of an upper neuron type injury or lesion to more of a lower motor neuron injury or lesion. So that would always be something that kind of, it not only is worsening spasticity something to consider, but suddenly improving spasticity in the chronic patient is also something that is definitely worth thinking a little bit more deeply about and maybe doing some neuroimaging. All right, that was all my questions. Anyone else with any final questions? Okay, so I'll take that as a no. This will be posted on YouTube for anybody who misses any of these lectures. And thanks again to Mike for an excellent presentation.
Thank you, everyone. Thank you, Dr. Abramoff.